From the JAMA Network, this is JAMA Oncology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Oncology.
Hello, this is Dr. Jack West from the City of Hope Comprehensive Cancer Center in Los Angeles and the web editor for JAMA Oncology with another audio author podcast. I'm very happy to be joined today by Dr. Frederick Bartels and Dr. Carsten Finke, both in the Department of Neurology at Charité Berlin in Germany. And they are here now to discuss their new publication in JAMA Oncology, Association between Neuronal Autoantibodies and Cognitive Impairment in Patients with Lung Cancer. Doctors Bartels and Finke, thank you both for joining today.
Hi, Jack. Thanks for having us.
Hi, thank you.
I'd like to start with some context. And one thing I learned from my training in thoracic oncology a couple of decades ago was that as we considered the potential for cognitive dysfunction when thinking about giving prophylactic cranial irradiation for, say, small cell lung cancer, I was directed to a pretty small amount of research that actually demonstrated that if you did detailed cognitive testing on patients with small cell lung cancer at baseline before treatment, many did have some cognitive deficits, but it required detailed testing. I hadn't heard of it being clearly related to anti-neuronal antibodies, and I don't know if there's really that much known about this. And maybe you can just comment on what the level of understanding is about the frequency of cognitive impairment at baseline. Is this well understood already?
Yeah, that's a very good point. And I think this is only recently begun to be better understood. And it was neglected for quite a while. And we now know, as you already said, that quite a relevant part of patients do have cognitive impairment and that it can occur independent of treatment. And before, it was long considered to be a consequence of chemotherapy, brain irradiation. Probably everybody knows the term chemo brain, which was pretty much stamped or coined in patients with breast cancer as well. But we now know that many patients with cancer, and especially also patients with lung cancer, do have cognitive impairment. What we don't know yet is what are the reasons, actually. Why do patients, before any treatment, develop cognitive impairment?
So you were looking at a cross-sectional study of patients with both small cell and non-small cell lung cancer, and you were looking at the prevalence of both neuronal autoantibodies and cognitive impairment throughout this population. Is that the main premise?
That's correct, yeah. So basically, the first question was, what's actually the prevalence of these neuronal autoantibodies? There was a shift or new discoveries of new types of neuronal autoantibodies in the last years. And we've been knowing those autoantibodies for quite some time in paraneoplastic neurological syndromes. Some additional new autoantibodies had been discovered in the last years. So our first question was, what's the prevalence of these new autoantibodies in lung cancer patients? And then the second question was whether those autoantibodies were potentially correlated with cognitive impairment in lung cancer patients. So we headed out and tested first the prevalence of autoantibodies, and then were very careful for the second question to exclude patients with potential confounders for cognitive impairment, such as brain metastasis, etc., to exclude those from cognitive testing. So we tested a subgroup of those patients for a correlation of autoantibodies and cognitive impairment.
Now, did all of your patients have brain imaging before starting? It wasn't just definition of or excluding patients with brain metastases who had been diagnosed clinically? Because one of the issues of prophylactic cranial irradiation trials is that if they didn't start with proactive looking with a brain MRI or at least a CT, you don't know if PCI is just treating clinically undetected brain metastases.
The patients that we included for the first question, we consecutively included all patients in the lung cancer center, so outpatient and patients in the ward. And we thoroughly performed neurological examination, and every patient that had any indication of neurological deficit had brain imaging, in addition to the previous staging diagnostic workup that all patients received there.
What kind of cognitive testing did you do? And was it at a particular point in their illness, say pre-treatment, or just at any time in the course of their illness?
So as we recruited the patients consecutively in the first hand without restriction, we had this cross-sectional design, basically including all the patients. We had some restriction in terms of surgery, so we made sure that surgery wasn't too recent. So we had a cut of a week beforehand, but then it turned out that all patients had surgery basically months before. So in the end, the median time from diagnosis was around 5 months. So it was a cross-sectional design with all stages of therapy included. And in the second stage, we analyzed if that had any correlation or any association with the findings that we had.
The other part of the questions you asked about the cognitive testing.
Right.
And as neurologists, we are interested in cognitive deficits in neurological disorders, and now also extended this to this group of patients. And we had a fairly extensive battery that we use also in the clinical setting here, which takes roughly about 90 minutes and really carefully tests for deficits of attention, working memory, long-term memory, also language and executive function. And it's a standardized battery. It has long been established. And as I said, it's in clinical use here in the Department of Neurology. So we use this standardized battery in all of the patients that underwent neuropsychological testing.
And overall, were these deficits ones that patients and family members would notice as symptoms, as challenges in their daily life, or were they often subtle enough that they would have to be elicited but not volunteered otherwise?
Yeah, that's a good question. I mean, it varies between patients, of course, and some had more subtle deficits, other deficits affecting several domains, also severe impairments. And for many patients, they're in a very difficult situation, and sometimes other problems are more in the forefront. But these are definitely cognitive impairments that patients themselves also experience, and that are also reported by relatives. So it's a range, but we cannot say that they, for example, have the level of a dementia, but maybe of a mild cognitive impairment.
Well, let's get on to some of the key findings. What was the frequency of neuronal autoantibodies that you saw in this population, both in small cell lung cancer and non-small cell?
So the overall prevalence of neural autoantibodies was 37%, combining small cell lung cancer and non-small cell lung cancer, with a higher prevalence in small cell lung cancer of 45% and a prevalence of 34% in non-small cell lung cancer. Now, we took two different approaches for those neural autoantibodies. One was that we tested for known neuronal autoantibodies that had been identified in the past with a cell-based assay. And the second approach was that we used frozen brain tissue from rodents and monkeys to test for neural autoantibodies that are not known, but that show binding, so IgG, immunoglobulin G binding to brain tissue sections. So the 37% is combining those. And overall, we found around 20% of all patients had neural autoantibodies that we know. And an additional 17% had neural autoantibodies that we haven't identified yet, but that bind to brain tissue. And that was a surprising large percentage of patients that we hadn't expected before.
How frequent was cognitive impairment, and importantly, was it associated with detecting autoantibodies?
So cognitive impairment was found in 67%, which is quite high. So meaning that 2/3 of patients showed cognitive impairment. And for the definition of cognitive impairment, we followed guidelines from an international consortium that came up with criteria how to better compare the definition of cognitive impairment across studies. So following those recommendations, those criteria, 67% showed cognitive impairment, which with a similar frequency in small cell lung cancer and non-small cell lung cancer patients. So we didn't see a huge difference in there.
Now, that seems high relative to what you might expect clinically based on us treating these patients. Was that a high number to you? And do you have a sense of how that compares to other patient populations with cancer or patients with smoking history and emphysema? 2/3 with cognitive impairment is a higher number than I would imagine you might have had going in.
You're right. And this is Probably partly due to the sensitivity of the testing. And as we said before, there is, of course, a range. And some of the patients have milder deficits and some of the patients have more severe deficits. And some of them will only be detected in a dedicated assessment like we did. To maybe put this a little bit in comparison, we did a similar study in melanoma patients. And here we found that cognitive impairment was less prevalent in about 1/3 of patients. And this is also the experience in general that patients with small cell lung cancer are those patients that have the highest rate of paraneoplastic syndromes, the highest rate of neuronal autoantibodies. And this somehow also fits to the observations that they have higher prevalence of neuronal autoantibodies and also a higher rate of cognitive impairment, as we saw here, these 2/3 versus the 1/3 in melanoma patients. And we're also looking into other tumor cohorts, for example, prostate cancer, also breast cancer, and we can basically see similar associations between neuronal autoantibodies and cognitive impairment also in these other cohorts. But the prevalence of cognitive impairment definitely is the highest in patients with lung cancer.
Now, this work can't speak to the question of whether the presence of neuronal autoantibodies decreases with successful treatment or increases as the cancer progresses, right? We don't have good information on these questions of both cognitive function and the presence or trajectory of neuronal autoantibodies over time in treatment. Is that fair to say?
Yeah, that's correct. And I think you're mentioning here an important next step that needs to be done, that it's a longitudinal study, ideally with repeated assessments of cognitive function and also repeated assessment of the prevalence or the detection of neuronal autoantibodies. This also taps into another very interesting question. We still want to further clarify if there are differences between different subtypes of tumors, and also how the prevalence of autoantibodies also maybe associates with overall tumor outcome. So we know from paraneoplastic syndromes that in some of these observations, patients with paraneoplastic syndromes, patients with autoantibodies indeed have a better outcome. Why could this be? The idea is that basically the immune system is fighting the tumor here by producing autoantibodies, and it might actually be successful, at least to some extent, in some of these patients. And that's another reason why longitudinal studies would be very interesting.
What's also been a big change in lung cancer, as well as much of oncology, specifically solid tumor oncology, is that immunotherapies designed to stimulate the native immune system and activate it against the cancer have become very integrated into our standard treatments for most patients with at least locally advanced and metastatic non-small cell and extensive stage small cell now. But we don't have any idea yet, but I think it would be a very interesting question of what the impact of an increasingly activated immune system has on autoantibodies and this whole effect.
In this study, when you started the study, when you collected the data, those treatments, so specifically immune checkpoint inhibitors, were just on the verge of entering the clinics here. So in our study, we have not enough data to answer that. It was only very few patients that received that. We have seen a little indication in another study on melanoma, where there were a little more patients with immune checkpoint inhibitor, that indicated that actually the prevalence of autoantibodies might have been higher or might be higher in those patients. And specifically regarding those immune-related adverse events in those treatments, this is, I think, a very important and very interesting question that requires further study.
Absolutely. So do you see there being clinical implications of the work that you're presenting here at this time, or what do you see as the next steps from here?
Yeah, as I said before, I think it would be important to have longitudinal studies, ideally in larger cohorts. And at the moment, we see this association between antibodies and cognitive impairment. And as Frederick mentioned before, so we identified two different classes of autoantibodies. Antibodies targeting structures on the cell surface that could be receptors, for example, the NMDA receptor, and antibodies targeting intracellular antigens. And we know that the antibodies or patients that have antibodies targeting the cell surface antigens typically respond very well if they are associated with a paraneoplastic syndrome, or if they are detected in patients with autoimmune encephalitis, which is a different disease, but they also have antibodies. So what we do know is that these patients respond to immunotherapy. So in theory, this could potentially be an approach that this cancer-related cognitive impairment would be treatable. But this, of course, is now far from transferable to the clinic. We would still need more studies that actually foster this relationship and maybe even better show a direct causal link between the antibodies and the cognitive impairment.
Well, Frederick and Karsten, thank you so much for taking the time. And this is really a very interesting and fast-moving topic, I think, with the integration of immunotherapy mixing in and still needing to learn about how all of these variables change over time and with treatment. So congratulations on your publication and for moving this topic forward.
Thanks a lot.
Thank you very much.
I'd encourage people to go to JAMAnetworkAudio.com or wherever you get your podcast audio for additional JAMA Network content. Until next time, this is Jack West for JAMA Oncology and the JAMA Network.